Good afternoon. Wonderful, wonderful, wonderful. Thank you for joining us today for our Better Together lecture with Dr. Sandra Eades. This event is co-sponsored by the Harvard University Native American Program, HUNAP, the HMS Center for Bioethics, and the HMS Center for the History of Medicine at the Countway Library, where we are right now, and the HMS Department of Global Health, Social Medicine, and our Office for Diversity, Inclusion, and Community Partnership. My name is Joan Reed, Dean Joan Reed, and I lead that Office for Diversity, Inclusion, and Community Partnership, DICP. As we start today's program, I would like us to do an acknowledgement. Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. We pay respect to the people of the Massachusetts tribe, past and present, and honor the land itself, which remains sacred to the Massachusetts people. Please note that our event today is being recorded and live closed captioning is available. Our moderator will invite questions from the audience and through a Zoom after the lecture. Today's lecture is entitled Unlocking Cultural Healing, Australian Aboriginal Youth Health, Constitutional Recognition, and Treaty Aspirations with Dr. Sandra Eades, all the way from the University of Melbourne. Not around the corner. And I'm now going to turn this over to my esteemed colleague, Dr. Joseph Gunn, who is Professor of Global Health and Social Medicine at Harvard Medical School.
Hello and welcome, and thank you, Dean Reed, for that opening. My name is Joe Gahn, as you heard, and I'm a professor of global health and social medicine here at Harvard Medical School, also a professor of anthropology in the Faculty of Arts and Sciences, and an enrolled member of the Ani Grovant Tribal Nation of Montana. I'm an alum of Harvard College from 1992, and I'm currently the faculty director of the Harvard University Native American Program, or HUNAP. HUNAP is charged with supporting the Native American and Indigenous community here at Harvard, in keeping with the Harvard Charter of 1650, which commits our institution to the, quote, education of the English and Indian youth of this country, unquote. Our HUNAP community is comprised of some 330 Native American and Indigenous students, over a dozen faculty with scholarly interest and expertise in Indigenous issues, more than a dozen staff members, both in HUNAP and elsewhere around campus, and around 1,400 Indigenous alums of Harvard University. We also recognize as part of our HUNAP community the thousands of our Indigenous ancestors who remain here at Harvard's Peabody Museum of Archaeology and Ethnology while awaiting repatriation back to their homelands. Part of the seminar series today originates from what we've labeled the Indigenous Health Seminar Series, which began in February of 2021 as a partnership between HUNAP and my Department of Global Health and Social Medicine. We've had about 10 lectures since then, and because of the pandemic, our first lecture, which was scheduled to be in person, went online or virtual, and all 10 of those lectures have been virtual or online. Now, as you know, there's beneficial outcomes from having virtual stuff. One in this instance has been we're able to circulate the registration link for these programs all throughout Indian country, in the United States and in Canada. And so we're able to have lots of Native and Indigenous people benefit from these lectures in ways that aren't the case always if they're in person. But it's really nice to have an in-person event too. And I'm so grateful to you, Dean Reed, and to all of the partners who you see here and heard acknowledged already, who've come together to make this possible today for our first in-person Indigenous Health Seminar. I'm very pleased to host Professor Sandra Eades as that first in-person lecture today, and to do so with the support and sponsorship of this great team and coalition. Professor Sandra Eades is the Menang Noongar woman. Noongar means a person of the southwest of Western Australia, or the name for the original inhabitants of the southwest of Western Australia, who collectively are one of the largest Aboriginal cultural blocks in Australia. Noongar are made up of 14 different language groups, and each of these language groups correlates with different geographic areas with ecological distinctions. Noongar have ownership of their own knowledge and culture. Professor Eades is an esteemed Aboriginal health leader. She is Deputy Dean Indigenous in the Faculty of Medicine, Dentistry, and Health Sciences at the University of Melbourne, and is the Roden White Chair in Indigenous Health Equity. Sandra graduated in 1990 as one of a handful of Australia's first Aboriginal people to be trained in medicine. She went on to become the first Indigenous Australian to complete a medical degree and be awarded a PhD in medicine. She has led major reform to Australia's funding of Aboriginal health research, conceiving a process to write Australia's first national roadmap for Aboriginal health research. In 2002, she successfully presented a case for the National Health and Medical Research Council, Australia's leading expert body for health and medical research, to make Aboriginal health research a priority, embed Aboriginal people in the structure and committees of the committee, and commit at least 5% of national health funding to Aboriginal health. These changes were also maintained for the Medical Research Future Fund, a research fund set up by the Australian government in 2015. Professor Eades is trained in medicine, epidemiology, and public health, has 188 peer-reviewed publications. She's a co-author of the Indigenous Medicine book to be published in 2024 as part of a highly successful book series on the first knowledges in Australia. She leads several major research programs, including the establishment of the Next Generation Youth Health Study involving 1,200 Aboriginal youth. Her early research guided the integration of maternal and child health into comprehensive national Aboriginal primary health care programs. Sandra sits on the boards of the Burnett Institute for Medical Research in Melbourne, the Deval-Yurigan Aboriginal Health Service in Perth, Western Australia, and is the Chief Medical Advisor, First Nations Health, to the Heart Foundation of Australia. And I was so pleased to meet Professor Eades when I traveled to Melbourne a couple of years ago and had a chance to lecture to their constituents at the University of Melbourne. And so it's really wonderful to be able to reciprocate the opportunity and have a chance to hear from you here today. As you've already heard, the title of Professor Eades' lecture is Unlocking Cultural Healing, Australian Aboriginal Youth Health, Constitutional Recognition, and Treaty Aspirations. Please join me in welcoming Professor Eades to Harvard Medical School.
Thank you, Professor Gon and Professor Reid, for your welcome. It's a great honour to be here with everyone today and to be able to share. I would also like to acknowledge the Massachusetts people on whose ancestral lands we meet today and pay my respects, as we do in Australia, to their ancestors and leaders past, present and emerging. And I always include emerging because I know that Indigenous young people don't have a choice. They do become leaders and spokespersons for their communities and the causes for Indigenous people. We were so honoured to have Professor Gon visit 2 years ago. We've set up an international speakers series. We have a visiting Global Indigenous Health Fellow, and it was such a wonderful launch. We're now into our 3rd year and we hope to continue those global partnerships. I've actually got a lot to say. I've probably crammed too much in, but I just want to make a few points. So I hope they'll come through at the end, and I'll try to get through things efficiently and leave time for us to have a conversation and a discussion at the end. So thank you all for your attendance and your interest. I always also begin acknowledging the importance of the United Nations Declaration on the Rights of Indigenous Peoples. Joe and I can remember the years when this document didn't exist and it didn't help focus and concentrate global attention on the needs of Indigenous people all over the world. I thought I would start with this because I don't know if you know the longevity and the history of Indigenous Australians. We are the longest living cultures in the world. In different parts of the country, our ancestors have been there for more than 60,000 years. So it's hard to, really grapple with what that means. And last week at the Venice Biennale, as the Australia Pavilion for the first time in history won the award for the Golden Lion Award, and a renowned Indigenous artist from Brisbane put together Kith and Kin, an installation where he's drawn across the ceiling and all the four walls his family tree and his lineage, both factual and theoretical, to try to symbolise that the ancient history that our communities have and the longevity of our people. My family history, as Joe's mentioned, I'm a Menang Noongar woman from southwest WA. Compared to North America, the disruption to our communities is recent, and it's so recent that the man in the picture is my maternal grandmother's great uncle. He's the half brother of her grandmother, and he was the chief or the leader in the area of Albany or Kingaling in 1890 when self-government was declared. And he petitioned and made the point that agents of the British Crown had stolen his people's lands. And so Joe's research and many other Indigenous scholars covers the area of historical trauma. And so my work and my professional life is built off trying to repair some of the historical trauma my people have experienced and other Indigenous people in Australia. But we're very fortunate. We are the only tribal group in Australia with a contemporary current treaty, and it was signed and recognised in the West Australian Parliament in 2016, and only 3% of our land mass wasn't privatised, essentially. So I won't go into the details of this treaty, but it's the only contemporary modern treaty signed between any Australian government and any Indigenous people, but it doesn't give money to individuals like me, but it sets up an economic base for communities and community functions, governance, joint management of national parks, land and housing, and a land estate that partially compensates us. And really, hopefully, I won't be around for 50 to 100 years to see the real impact of some of this work to repair our past, but I'm really incredibly happy about this. So we had a terrible year in Australia last year. We had a referendum to establish a voice to Parliament. It didn't pass, but referendums rarely pass in Australia. So beyond that referendum, there are still ongoing work in different states and territories for governments to actually negotiate treaty settlements with Aboriginal people. I live and work in the state of Victoria, and Victoria is the region of Australia where treaties and treaty settlements are most progressed. And so you can see some of the details of that treaty. It is a political process, though. The treaty our people signed was a legal process and it required legal settlement. And this is a political process. So we're uncertain of the outcome of this and other treaties at the moment. So one of our great successes in health has been the establishment of community-controlled primary health care. NACCHO is the National Aboriginal Community Controlled Health Organisation. There are 26 million Australians and about 1 million Indigenous Australians. So 1 in 26 of Australians are Indigenous. We have a life expectancy that's approximately 10 years less on average than other Australians in a range of different health inequalities. These services were, the first were set up in the early 1970s, and there are 145 different services around the country. And I sit on the board of one of these services. So NACCHO represents these member organisations that are community controlled And really, Australia does fund primary care, universal primary health care to all Australians. So it's not unreasonable that one of our greatest successes as Indigenous Australians would be originally setting these up as volunteer-based organisations, but now fully funded, fully integrated, fully a part of the Australian healthcare system for Indigenous Australians. So some of the oldest celebrated their 50 years of existence last year and the year before. The original was established in Redfern in Sydney in 1972. Derbyl Yerrigan is the Noongar name for the Swan River in Perth, and I sit on the board of the Derbyl Yerrigan Health Service in Perth. But that's one of the major successes. So the one service I've been most closely involved with celebrated 50 years of operation last year, and it started, as I said, staffed by volunteer doctors, community volunteers, unpaid workers, and then a small budget of $100,000 per year and 400 patients in 1973, and it now has more than 20,000 or almost 20,000 patients and a budget of $22.7 million, and it is an important part of what helps address the health inequalities experienced by Aboriginal people. And we really saw that contribution come to the fore during COVID-19. All over the world, Indigenous people were really suffering and really experiencing having a different experience with COVID-19 than we as Indigenous people had in Australia. It was, in recent history, the only time the gap in health status was reversed, even temporarily, where the rate of COVID was lower amongst Indigenous Australians. And it was that strong network of community-controlled primary care services and the public health response and the way the Australian government and state and territory governments could mobilise that existing network of services that made the difference in that instance. So we have made progress with addressing health inequalities for Indigenous Australians, but there is so much more work to do. You know, it's been very difficult to really reduce rates of incarceration, address the social determinants of health, increase levels of education and employment, reduce and eliminate the ongoing removal of Aboriginal children from their families. But I took heart in attending the Healing Our Spirit Worldwide meeting, a global meeting of Indigenous health practitioners and scholars in Vancouver, Canada last year. And the take-home message, I had attended that meeting in the early 1990s. In so many ways, the take-home message from that meeting was that health services, clinics, hospital access are necessary, but they're not sufficient to secure our collective health and well-being into the future. So I went home and I thought about that, and some of the work Joe and our colleague Alastair Vance progress is focused on mental health and well-being and the importance of culture and culture as a treatment, culture as a remedy to improve mental health has been really clear. But I also started to think about physical health and, you know, the connection between mind, body, spirit, and how much following on from that meeting, culture, the role that culture could and should play in helping us address these really difficult inequalities that persist, along with, you know, the approaches to addressing the social determinants of health and the political economy of health and the place of Indigenous people, including through treaties and economic empowerment. So there are a lot of people beginning to think and write about what does a cultural approach to primary healthcare prevention look like. And one of the groups of speakers were from the US, Chelsea Luger and Throsh Collins. I'm not sure if any of you have heard of them, but they've recently published the 7 Circles Indigenous Teachings for Living Well. And I've just listed the sorts of things they write about, and they link their theories to what they know of their tribes and their communities, and the Indigenous principles for living well from their cultural background, but also they link it to what they know of what evidence-based medicine, public health generally teach us about what's required to prevent disease. They cover movement, land, community, ceremony, sacred space, sleep, and food. And they seem like simple things to talk about, but increasingly we're thinking about how do we frame these, interact with community and integrate these approaches into tackling and addressing health inequalities. There's another writer, Linda Toohey Smith, who wrote a textbook called Decolonising Indigenous Health Research decades ago, and she's recently published Healing Ourselves, Indigenous Knowledge, Healing and Wellbeing. And there's a series of books being published in Australia about first knowledges, the knowledges of Indigenous Australians in relation to astronomy, law, biology, plants, design, and with Shawana Ranger is the director of the Posh Centre at Melbourne, and Fiona Stanley, who is non-Indigenous but was my PhD supervisor in the 1990s, and she directed an Institute for Child Health Research for over 20 years in Perth. We're the authors of First Knowledges, Medicine and Wellbeing, and that will be published very soon in coming months. But these are the sorts of resources that are available to everybody, and that can be read and considered in terms of addressing Indigenous health and wellbeing, and really integrating culture into that. Our colleague in Melbourne, Alistair Vance, is a child psychiatrist with decades of experience working in children's mental health at our children's hospital. And our work with Jo and I, but really led by Alistair, has been to integrate culture alongside Western biopsychosocial approaches to providing care for those children. So I just want to speak about one study and use it as an example of where I think it highlights where some of the opportunities are to integrate culture and culture-based approaches to remedying health. So the woman in the picture is our elder. I mean, her equivalent in Australia would be, she would be the chief, she would be the leader, the head of our tribe. In 2012, I visited and I really wanted to speak about diabetes and heart disease. And she said to me, look, everybody's doing diabetes and heart disease. We've got so much diabetes and heart disease research. No one's focusing on young people. Why don't you, go away and think about Aboriginal young people and their health and do something about it? So there I was. I had the elder who told me, off you go. This is the real priority. And I thought, well, no one's doing it because it's not easy to do. How do you engage with 10 to 24-year-olds? How do you engage with disadvantaged 10 to 24-year-olds? And, you know, the range of terrible concerns that still affect our human rights, justice issues that impact our young people. So we went away, we had success. We wrote a grant. We originally called it the Forgotten Generation, and people said, oh, that's too negative, needs a strength-based positive narrative. You can't call it the Forgotten Generation. So we renamed the cohort study. We have Wave 1 data, the Next Generation Youth Wellbeing Study, and we brought together collaborators from 3 different states and territories in Australia, and these are some of our original staff and some of our original collaborators. And we all know the importance of young people. That's my niece in the playing football, Australian rules football, and all of the photos have been used with the appropriate permissions. But the triple dividend that comes from focusing on young people for their current health, their future health, and the health of the next generation of young Indigenous Australians or young people globally. So we set up this study. We have completed Wave 1 data collection, and the study aimed to understand the factors that determine future health and wellbeing for Aboriginal adolescents and young people, and to inform the development of health services and health and social policy. The phase 1 of Wave 1 was qualitative and co-design and speaking with young people, healthcare providers, parents and carers, people in community. And phase 2 was the rollout of a survey with collection of clinical data. So we had strong buy-in from local communities where we engaged with health service partners and community partners. We didn't know where we would find young people because they're not sitting in a primary care waiting room waiting for a researcher to come up and invite them to participate in their study. And we had great difficulty doing our research with schools because schools prefer to keep students' time for education, not research and other things. So, but we did find them. We rolled out the survey and a range of fairly basic clinical measures because we were trying to simplify the process. Our survey had 6 domains, and for the older participants, the younger participants, 10 to 15, didn't complete these sexual and reproductive health domains or the questions about tobacco, alcohol and other drugs use. But it was not focused on any one aspect of adolescent young people's health, but it was a global study of young people's health. So we've published various papers from this work. A recent paper about how we engage with community called Developing the Murudja Solid Family and Country, the relational community framework, because we actually found young people in places where they felt safe, in neighbourhood centres, in communities, in the houses of community connectors or neighbourhood centres. We didn't engage with young people in any place where they were separate from elders and carers from the communities that they came from. And so we published some studies from the beginning, some papers from the beginning of this. What I want to focus on, I want to tell you briefly about the mental health domains and then really focus on cardiovascular disease, early cardiovascular disease risk. So about 40% of our young people had high levels of psychological distress. And when we asked both groups, have you ever wanted to see a doctor or counsellor or mental health professional but didn't or couldn't, over 10% of the younger age group had difficulty, and almost 20% of the older age group had difficulty. So gaps in services, and you can see what were the problems, didn't know where to find one, difficult to get an appointment, and the cost, and worried about stigma and what other people might think about you as a young person needing to seek help for a mental health problem. And yet, Indigenous Australian young people have some of the highest youth suicide rates in the world, and they have urgent and unmet needs for care. So I can't tell you in detail about this part of our work, but Professor Gon's an ongoing collaborator, a valued friend and collaborator, and we've got a number of studies, and at least two. It's known as the Noongar Budja Youth Wellbeing Project, and it's about bringing family, community, culture and country to the centre of healthcare, not the periphery, but to the centre, and developing culturally appropriate models for improving mental health and wellbeing in Aboriginal young people. So we have a tertiary hospital-based project, and we're about to trial a model of using youth workers and service navigators to help connect young people who are screened in on the basis of high psychological distress to assist with accessing care. And we have more detailed work looking at patterns of suicide amongst youth in large-scale linked data in Australia. So, and I mean, just to reiterate further, these are some of the things that young people and their parents and carers say about the difficulties accessing mental health care and what might remedy that or make it better. Now, I really want to jump into the next part of the story, and that's really about the problem of early risk factors for cardiovascular disease in this cohort. And we're probably the third large study to highlight this problem. And I'm not going to show you the blood pressure data, but in our study, about 20% of young people, 10 to 20, had hypertension in our surveys. So the question is, the American Academy of Pediatrics provides some of the only guidance globally about how to manage this. Do you take a clinical route and, it's all about clinic screening and medical management of hypertension, or are there other alternatives that are built around their culture and their capabilities and investment in prevention? So this is in relation to presenting data on healthy body weight, healthy BMI. And so we had more than 1,200 data on more than 1,200 participants aged 10 to 24. It was easier to recruit younger people. It was easier to recruit females. And most of our cohort came from a single state in West Australia. So we try to avoid stigmatising Indigenous people in our research and presenting negative outcomes. We do sometimes, as in the case of thinking about hypertension and how to detect and whether or not to treat and how to manage that. But the outcome in this case was healthy waist to hip ratio or healthy BMI. You can see that 64% had a healthy waist to hip ratio, 48% had a healthy BMI. But along the bottom are the age groups from 10 to 11 across to 22 to 24. And you can see that by the time as you get older, people, less of the group are a healthy body weight. So that's down to less than a third if you use BMI, and about 40% if you use waist to hip ratio. And for a range of other markers of cardiometabolic risk, whether it's blood pressure, HbA1c, you can see the majority of young people have measures that are in the ideal range, but if you look at the overall profile, only 23% of our cohort had ideal measures. And so we looked at movement and sleep, and you'll remember, you know, that approach to Indigenous wellness and healing talked about movement and talked about sleep. So if you were physically active 5 to 7 days of the week as a young person, you are much more likely to be a healthy BMI or have a healthy waist to hip ratio. If you slept 7 to 10 hours a night, most nights, you're also much more likely to have a healthy body weight by either of those measures. So you can see the way in which those factors are influencing, those factors that are clear in the cultural guides to health are impacting these outcomes in young Aboriginal people. The social determinants clearly have an effect. If you were reliant on government income, if you lived in a home that was overcrowded, you were less likely to be a healthy body weight. If you had caregivers who were university educated, you were more likely to have a healthy body weight, and that seems more important than your carer's employment status. So you can see the sorts of factors that come to the fore in these data that we have, and considering those two pathways, you know, a very clinical screening, evidence-based medicine, treating hypertension medically in these young people versus funding prevention programs and addressing some of the basis for these risk factors becomes much, much clearer. So we also looked at smoking, and smoking on average shortens using our Australian data, shortens life expectancy by 10 years on average. Not the traditional use of tobacco in Indigenous communities in North America, but the capital-driven, market-driven use of tobacco globally has been terrible for Indigenous people's health in Australia, with more than 50% of Indigenous Australians smoking, and now that's down to less than 40%. We found these data are presented in the way we feed back to the communities that share with us, but we found that only 10% of 10 to 15-year-olds had ever smoked, and we found that on average they had their first cigarette at 11 to 12 years of age. So one way of tackling that, which is addressed in those Indigenous frameworks to health and wellbeing, is around sacred space and your personhood, is through those frameworks. But the top 3 reasons young people gave for never smoking, we often design these health promotion programs and we don't know if they were concerns about health, family and friends advice, and no reason, but living in smoke-free homes and having non-smoking friends was effective. And these other factors were also important. So, and if you read those frameworks and think about the approaches where culture can play a role in improving young people's health, where we can take a medical approach, but we can also take a public health and a prevention approach where culture is at the centre, then all of these factors can be addressed with that cultural framework and approach. The other final part of the data I'll show you very quickly and then finish there, and look forward to discussing those frameworks with Dr. Gone, was physical activity. So we know that physical activity and movement is a part of our traditional life and culture. We've been westernised. Busy academics find it difficult to keep that cultural balance, but also people living in disadvantaged neighbourhoods, communities experiencing the most severe of inequalities experience that. But however, having said that, Indigenous children on average are more active over ages 5 to 8 up to 15 to 17 than other Australian children. And but again, at older age groups, the level of physical activity drops off very rapidly. And we didn't know completely what the picture was for adolescents in relation to physical activity. So sport and physical activity play important roles for Aboriginal and Torres Strait Islander young people. But in general, we see higher rates of participation amongst males than females. And in this study, we asked young people outside of school hours in the past week, how many days did you exercise or play sport or games that made you sweat and breathe hard for at least 3 days a week or more? And we asked about these other covariates. And we ran regression models that were sex stratified. And again, you can see that for both in the dark blue line, almost 70% of young people meet those physical activity guides at age 10, and that drops down to less than 30% of young people at age 24. And what predicted whether you were meeting those levels of physical activity? Well, if you were male, so partly it's a gendered story, with females less likely than males. Screen time, recreational screen time, if you had less than 2 hours of screen time, you had a higher level of physical activity relative to other young people. And your peer group matters. If you had friends who smoke, if you had no friends who smoke, and if you had friends who drank less alcohol, then the clustering of good health behaviours and negative go together. And the picture was different for males and females. So, you know, a gendered, cultured approach to young people's health, I think, is preferable to really taking Indigenous young people down a medical pathway without prevention and culture in the picture. So I'm just flicking through some of the rest of this because we're almost at 11:45, Joe, and you can see young people with higher physical activity had better self-rated health. They also lived in communities where there were things for young people to do. They had higher resilience scores. Interestingly, they were more likely to be involved in team, individual, sport, church and religious groups. They were more socially engaged. And I mean, some of this youth, you might think, oh, what's the relevance of this? The relevance is that it impacts government policy and programs. In 2014, the Australian government cut $500 million a year of spending in Indigenous communities. And I think what they did was they had the must-haves and the nice-to-haves. And the must-haves are clinics where you can be screened, have your blood pressure treated. And the nice-to-haves are community groups, youth centres, the things that our data show are core to prevention, the extent to which we're able to socially engage and mobilise and support Aboriginal young people. So So that's all I'd like to say. Thank you. I've tried to use some of the data from our studies to highlight where the opportunities might be for culture to really have a leading role in our future efforts to address Indigenous health inequalities. Thank you.
Well, thank you, Professor Eades, for that really engaging work and an opportunity to get a glimpse of the health and well-being of Aboriginal young people and Aboriginal people in Australia more generally. I'm sorry? Mhm. So we're eager to take some questions today, and we'll do so, of course, from our in-person audience, but we also have an audience that's virtual, and so I'll also be dividing my time and attention a little bit from listening, of course, to Professor Eades' responses, but also wanting to look into the questions that are coming in through the virtual side as well. Let me just start, though, maybe with a question that speaks to this kind of cross-national interaction that we're having right here in this sort of exchange. There are perhaps 400 million Indigenous peoples comprising some 5,000 descent communities around the world. And given the varieties in Indigenous histories and cultural experiences and practices, I'm wondering, what you see as the most important aspects for building coalitions cross-nationally for improved health.
Yeah, I think it's an important problem, Joe. You say there are 400 million globally, but you and I both know that in our respective countries, we're 2 to 3% of the population, and without building a global community and a global community of practice, we have the problem of being a minority group, and we have the problem of actually I first came to North America in my final year of medicine. I visited Montreal, and I've been coming back ever since because it's stunning the way the colonial history and the whole colonial project has impacted our communities. And I don't know how you feel, but I feel like partly I'm living in a renaissance of Indigenous culture, Indigenous authority, and really, I really embraced science, and I thought science had all of the answers, but sociology, politics, economics, the whole thing about being able to recover from those oppressive periods in our history and really centre our culture and shape future policy and whatever we do in that way is so important to me. So, having you visit with us in Melbourne, but also being able to reciprocate and be with you here at Harvard's incredibly important.
I agree with that. Thank you. One other question I had for you, it perhaps pertains to some of the variations cross-nationally. When I visited you all in Melbourne and in the Victoria region, and then came home and thinking about the importance of this concept of country in Aboriginal Australia. And I wonder if you could talk a little bit more about country and what its importance is for health among Aboriginal Australians.
Yeah, well, Noongar, the word for my tribe, means man or person, and there's a word called Bibbulmun, which is similar to Noongar, and it literally means people who drank from the breast of the land. The land nurtures you. You don't have a sense that your existence, your whole being is any way separate from that land. So country is very central to health. And more and more in the mental health work with you and Alistair, I realise how country nurtures you, cares for you, and your relation and your responsibility to the planet are bound up with your relation to country. And so I really, it's hard to actually conceptualize how dependent we as Indigenous people are on our country, the country that our ancestors have been connected to, and how we not only inherit that country, but we inherit the responsibility to care for that country and all of our relations, you know, the fish, the bird, we never take more than we need to, and we always have that preservation. And there are rhythms in the planet, you know, that when we live in cities, we're not exposed to, and there's a lot of global literature about how good nature is for your mental health, being in nature, bathing in nature, you know, that exposure. So it's not just what we as Indigenous people understand, but it's really the literature about well-being that supports that important sense of country. Yeah.
Well, Earth as Mother, that does seem to be a commonality in some important ways. I think I saw a hand maybe at the back. Yes, please. I think there's a mic coming around.
Thank you so much for your talk. That was so interesting to hear. I'm Maple, I'm from New Zealand, and we met just earlier today. I had two questions. My first question was, when I worked in Arnhem Land, there's a high prevalence, I suppose, of Indigenous people there, and I wondered whether there was a rationale to exclude the Northern Territory from the study that you did, whether it was logistics or something else. And my second question was, I worked in addiction medicine and saw a high number of Indigenous youth come through in addiction and drug rehabilitation. And I wondered, how could we use the cultural lens to help this group of people in the way that you've been presenting today?
The Northern Territory, the Arnhem Land's in the top end of the Northern Territory, and we did collaborate with partners in Alice Springs, which is right in the centre of Australia. But the population is relatively small. So over 2 years, we recruited just over 100 Aboriginal young people from Central Australia. But having said that, you know, if you look at blood pressure, their outcomes were always far worse than the people living in the other populated states that we worked with. When I lived in the Northern Territory 20 years ago, there were only 200,000 people in total in the Northern Territory, and 30% of the population that in that territory were Aboriginal. So Australia varies. The vast majority of Indigenous Australians live where all other Australians live, up and down the East Coast and on the southwest corner and partially in South Australia. So it was really the logistics and the sheer number of people. Joe would be better able to answer your second question. I think culture has a powerful and important role in addressing addictions, but also addressing the broader historical trauma experienced by Indigenous people, and you know, the distinction between the experience of individuals, but the collective experience and the collective trauma that we've experienced over time.
I mean, you have talked about addressing or repairing historical trauma. It's interesting because you also talked about the Noongar Treaty, and in part how it affords or is addressing a need for an economic base.
Yes.
And I do wonder, you know, historical trauma has to do in part with consciousness of colonialism and subjugation, oppression, marginality, discrimination, those sorts of things. An economic base, you know, gives you a livelihood.
Yes.
And I do wonder how you see the relationship between those, or what should be primary, secondary, if anything.
Well, the other emphasis I should have given was, you know, we have a special status in that region because of the treaty. We are joint managers of national parks. We have equal authority with the West Australian government to manage those national parks. We have handback of tracts of land, and really what was stolen from us was land and the ability to practice our culture on our land. So what we want more than money in the bank is the ability to be back on land. And there are special measures where, as a Noongar person, I can now camp for up to 28 days wherever I want in a national park. And if I want to bring my dog with me, I can, as long as I manage my dog, because dogs are, a part of our culture. So there's a way in which the treaty actually restores our access to land. I remember as a young person being chased off paddocks and farms. I grew up in the country and being told I was trespassing on somebody else's land. And I think for my community, we're just going to gradually begin to realise the enormity of not having our land stolen and being impoverished, marginalised fringe groups in society, that will go a long way to repairing the damage and the historical trauma that we've experienced.
Yeah. Part of your findings were about educational background or socioeconomic status and the relationship to health outcomes. And this is a common Indigenous story, I think, wherever you kind of look at these sorts of data. But I just want to ask again about livelihood. I wonder to what degree, we think of, you've pointed out already that health services aren't necessarily, the full answer to how we can recover and reclaim well-being in our communities. What role does livelihood play in terms of like a job and an income and those sorts of things?
Yeah, I think there are many ways in which people are marginalised and they suffer. They begin to suffer when they're young because they struggle and they have problems with literacy. A huge number of the young people in our studies weren't literate enough to fill out our as simple as we could make them, questionnaires. And in a non-stigmatising way, our team had to understand and kind of problem solve and not shame young people who weren't literate enough to fill out our surveys and sit with them and carefully. You're marginalised if you've got a justice system that's quick to question you, charge you, send you to prison. Australian prisons are overflowing with Aboriginal young people and older people. And you're marginalised if you don't have a job and you don't have a meaningful way to survive and thrive and not be at the whim of government bureaucracies and, having those layers of disadvantage that many Aboriginal people experience. So employment programs, education. When I attended university in the 1980s, there were 3,000 Aboriginal young people at university at any one time. There's about 20,000 at any one time now. But that's really an intergenerational story. What really happened was the exclusion of Aboriginal people from education and the Australian economy, as well as the marginalisation of their culture, and the repair and remedy for that doesn't occur in one generation. I'm the first generation to complete high school, go to university, and you have to do everything, complete a PhD, become a professor, everything. And even as professional people, we carry these dual burdens of understanding how inequalities are experienced in our communities and also being the advocates and the champions and being a champion for students. And what Joe and I are interested in is helping students come to elite institutions like Harvard and Melbourne and feel like they belong, that they can really be here and that they can thrive, and that increasingly over generations, this won't be an uncommon story, it'll be a very common story. But we don't have to leave our culture at the door. When I went to university in the 90s, my family worried I'd lose my culture, I'd have to leave it at the door, become enculturated, and that I couldn't hold both together. But so that's the importance of, finding ways to enable people to thrive culturally as well as educationally in our institutions.
Let's take a comment from our virtual audience. Someone writes, in Brazil, the Indigenous youth want to live in the cities and go to university. They used to say their parents are so naive, we must stay in the cities. in Australia, how do the youth view cities?
Well, most Indigenous youth do live in cities because most Australians live in cities and most Indigenous people live in cities. But you can be on country in cities because just like Boston's the ancestral home of Indigenous people, Melbourne, Naarm is the ancestral home of the Wurundjeri people. And, you know, we can be in cities, but we can also be on country and have the benefits of country outside of our cities. So they're not mutually exclusive. Both you and I have professional lives where we can spend a month or two of the year working on country. Most of my research is in Western Australia, and increasingly I spend most of the year in the university inner city. But for people with less power and agency than us, we need to ensure that that's a reality for all Indigenous people.
You talked about the challenge of, you know, on the one hand, a commitment to avoiding stigma in the work that we do. On the other hand, of course, trying to really research into some of the issues that are a challenge for the health of Indigenous or Aboriginal peoples. We have a question here that maybe touches on that a bit, which is, you know, do you work with internal violence among Indigenous youth? And if so, how do you go about that relative to these trade-offs of representation and stereotype and stigma?
We didn't really. There is very strong interpersonal violence. That's a part of the way trauma is expressed in our communities. In Alice Springs in Central Australia, we've not sure if it's been in the media in North America, but we've had to introduce curfews for young people. And I know amongst Noongar young people, there's interpersonal violence, and it's an expression of the trauma and harm we've suffered over time. There are also forms of that violence, lateral violence, whereas Indigenous people, we are actually hostile towards each other. So in our professional lives, we have to come to grips with the form that trauma and trauma recovery takes for us, and that sometimes, as professional people, there are things we can do to avoid that interpersonal violence that occurs amongst adults.
Yeah. Please.
So a slightly different kind of question. You talk about this important treaty of 2016, and I would imagine there was some sort of advocacy and gathering and coming together to have a new treaty.
Yes.
And wondering about how that work of being able to do that might have impacted the youth, how they think about themselves, how they think about their agency, how they imagine being in the world, or as you talk about country, in a different way because of that. And is there also this possibility to use what's learned from that and apply it in other places that don't have that treaty, because the treaty wasn't for everyone?
No. I mean, the treaty arose because in Australian law, the Mabo case occurred in the 1990s, and the Mabo case established native title in Australian law, that a form of land ownership existed before the arrival of the British. And then there have been other land claims that have been successfully won. What distinguishes our land claim is we are a very large nation, and we didn't act separately, but we acted cooperatively, and we included the city of Perth. You know, leave no one behind. One of our tribal groups, their ancestral land was the city of Perth. So I can only imagine the wisdom of elders who were thinking about how to address the issue of stolen land before I was born and during my early life, and the path that they took to the realisation of that treaty. But I think young people are still coming to terms with it. It wasn't you know, there were some people in our community who never wanted their sovereignty to be lost in any way, and being recognised in another, under the British Crown in another system of law was giving away our sovereignty. But for others, we believed that compromises had to be made, and it was actually a very divisive process. The vote to accept that treaty passed easily in 5 tribal areas. In my tribal area, it almost didn't pass, and we were almost left behind and, you know, not a part of it was very, very contentious. So I think for young people with so much ongoing inequality, disadvantage, witnessing older people suffering and witnessing the suffering of other young people is still having an ongoing impact on Aboriginal young people. But I think they're also, it's early days. The treaty was signed in 2016 into our state government's legislation, but it wasn't. It's only really now being enacted, and the full impact I don't think's arrived. How will that translate to other young people in Australia? I mean, we're even more than that referendum. We're holding our breath about the outcome of state-based, politically driven treaty processes, particularly in the state of Victoria. It's like the Massachusetts of Australia. It's, you know, it's a very, if it can't happen in Victoria, it's unlikely to happen anywhere in Australia. So it really depends on that balance of a political process, not a process in Australian law. And I think perhaps the impact of that Victorian treaty will be statewide and go even further and really change in more profound ways, possibly, the status of Aboriginal people in that state. And then over time, in history, I hope that other states and territories follow as well.
We'll get you on mic here.
I'm wondering if you can comment on why the treaty was so contentious in your community, and any of the concerns that arose, have any of them since come to pass?
Well, no. Well, it was contentious because there's the far left, the far right, and the people in the middle. The far left of Aboriginal politics, we're no different to any other group in society, didn't want to recognise the British Crown under any conditions in Australia, and to come to that treaty settlement, it was an agreement making with contemporary agents of the British Crown. So, but many of the people who, my cousins are really well-known activists in Western Australia and led part of the opposition to the treaty. It divided families, but is now a staunch supporter, and there's very little resistance or opposition now. It's really a question of how to make these opportunities really work for our communities and for individuals, and how to alleviate suffering. It hasn't been a global panacea for the ills that affect our community. 50% of all Aboriginal children are reported to child protection authorities, and 10% of all Aboriginal children in the state of Western Australia are removed from their families. But these are colonial processes, and really it's treaties, but it's the whole project to decolonise societies around the world. And in Victoria, they're discussing ways in which to transition those child-related services, investigations, decisions about child welfare issues back to Aboriginal community control and management, because these are complicated issues, but so often in a colonized system, many of the values and, you know, the personal philosophies of people are not questioned, and there's never good, strong economic evaluation of the harm these colonial systems do, as opposed to the good that they produce and the ethical and moral decisions that are enacted in colonized systems.
Well, and you've had the privilege of working with Aboriginal adolescents, and adolescence is a time that's so remarkable because on the one hand, it's so much promise and potential. On the other hand, vulnerability and, you know, especially in Aboriginal communities, you know, marginality and the lack of opportunity sometimes. What in your work with Aboriginal adolescents leads you to be most concerned, and what leads you to be most hopeful?
Well, I'm hopeful. I worked in research institutes for decades and I made the shift to universities. I'm hopeful because I encounter remarkable young people who are mostly in health sciences, medicine, dentistry, nursing, psychology. And like you, Joe, I'm part of the system and trying to make it a positive and, you know, life-affirming educational experience. And all of those young people, I can see that we invest in them. The return is decades, you know. Who knew that when you graduated from university, you would spend 30, 40 years of your life thinking about the communities we come from, or for me. And so that's the way I view many of those young people. I used to say to my son, oh, look, I've been in the struggle. I did this now. If you go to university, become an architect, engineer, build a bridge, just do something. The world's your oyster, but none of them can do that because they inherit the history and they actually inherit leadership roles, whether they like it or not. But it's a long answer, but the students I encounter at my university fill me with hope and optimism about the future. The thing that concerns me is that these society-wide structural impediments to our people's well-being still exist, whether it's a child welfare system that has, you know, racial bias in the way it assesses whether you're an appropriate or an effective or a safe parent and chooses. I've worked in family medicine and spoken to adults with addictions who were in those systems and lived in 15 or 20 different households and never felt loved. And I know those systems traumatize people. So until that example and other examples are dismantled structurally, there are still important threats to Indigenous young people, both in Australia and other parts of the world. Yeah.
Maybe our last question, please.
Hi, thank you. My name is Franny Polanco-Walters, and I'm an adolescent medicine specialist at Boston Children's Hospital. So it was really nice to see you talking about adolescents. One of the things that I noticed when during my clinic sessions is that my adolescent patients are also struggling with sleep. And I find that video games, Netflix, and even sometimes mostly homework competes with their sleep. What's competing with the sleep with adolescents, Aboriginal adolescents in Australia?
Well, I think all of those things are the same for Aboriginal people: screen time, video, but I also think there are other things about poverty. Their mental health disrupts their sleep. In our study, we found 40% of young people had high levels of psychological distress. So we also found in clinical settings, those primary care settings, the healthcare workers are geared towards maternal, child health, adult chronic disease management, cancer screening. They're not well equipped for detecting and intervening and scaffolding and supporting young people with mental health problems. So I would say their actual unrecognized, untreated mental health problems are interfering with their sleep terribly, as well as the other factors that exist for other young people with screen time. And probably witnessing ongoing trauma, grief and loss, death of young people, death of many relatives. That's not an uncommon experience. So the experience of adverse life events in any 1 year period is also quite different.
On that note, let me turn it back over to Dean Reed to close us out this afternoon, please.
So I want to thank you for the work that you do, your commitment to this work and to your community. But I'd say it's communities of not just Indigenous, it's communities that are on the margins and what it means to be on the margins. And thank you for sharing. Much to learn here. So thank you for your presentation. Thank you for your work. I'm looking forward to understanding what more we can learn from this and the impact of some of these other changes and how that will play back with the youth. So I have to admit, I'm a pediatrician. So you have to understand this was dear to my heart. And Dr. Gunn, thank you for leading the question and answer. To the event sponsors today, HUNAP, Center for Bioethics, Center for History of Medicine, and the Department of Global Health and Social Medicine, thank you for partnering, for us coming together to sponsor today's program. I'm going to ask for those who are online, there is a poll to please fill out that poll to give us some feedback for today's session. Thank you to all of you for joining us and for us coming together. There's a part about seeing each other and coming together in community that is so very, very powerful. There are some more events that will be coming forward. May 8th is a Leadership and Faculty Development Program. May 9th, Minority Health Annual Policy Meeting and Reed Scholar Symposium. And then on May 15th, we are partnering with the New England Journal of Medicine in a series. It's a 3-part series on recognizing historical injustices in medicine that are part of the perspectives of the New England Journal. And there'll be speakers here from the 4 authors. Professor Gunn is one of those 4 authors for the 4 of the articles in the series that relate to Indigenous populations, slavery, civil rights, et cetera. So they're on our website. Please join us for that. And again, thank you for being with us today, and thank you for a wonderful presentation.
Thank you.